Good afternoon. Are you ready for this session? Immediate tooth replacement, one of the most controversial procedures there is. Because as you know, some people out there, they absolutely think that this type of procedure is dangerous. Should you do it? Should you not? And we're going to try to solve the puzzle today. Tristan and Edith, are you ready for your session?
Yes,
Yes, we are.
Next 20 minutes, we talk about the influence of implant position on long-term and short-term results of implants, aesthetics results in the aesthetic zone. We talk about materials, and we will look at it from a clinical and a scientific way. Doesn't work? Yes. I started more than 10 years ago with Nobel Active doing immediate cases. And in the beginning, I was not sure if I was on the right way. You saw from Jose, there was not many signs at that time. And I want to start with one case I did in 2008. A lost central, and I decided to do it immediate, creating a bit space before that implant. It was just an idea, not scientific, proven at that time. I could follow this patient because this is a patient of our own clinic. And we followed her in all the times. And I saw her with a 10-year result. And the 10-year result is still very stable. The question is this luck? Or is this what we can expect when we do this kind of a procedure? And I asked Edith, can you maybe explain if I was just lucky? Or did I make a good choice?
Actually, it was this case that you convinced me to step over fully from the delayed to the immediate protocol. And I asked you the question, what is the scientific background? So we started discussion in 2008, and when we started to place the first immediate implants together, there was no study published on this topic. So the only thing we knew from the delayed protocols was that we had to create a hard tissue crest in front of our implant of at least 2 millimeters to support the soft tissues. Also, there was some evidence given that by application of a bone substitute into the socket, we could diminish the horizontal bone loss and even gain vertical crestal height. If we look at the fresh extraction socket from the three-dimensional perspective, then we don't expect any buccal ingrowth of bone, because the buccal crest is very thin and mainly vascularized by the periodontal ligament. So at that time, when we discussed our protocol, we considered the fresh extraction socket as a three-dimensional bone defect, which is very predictable to graft, and the buccal crest was considered as the natural resorbable membrane. Also, we started to understand why immediate placement often was related to mid-buccal recessions, because we were learned to place a wide diameter implant into the extraction socket, forming an obstruction for new bone formation. So in 2008, we imagined that by application of a bone substitute into the extraction socket and placement of a narrower implant maximal to the palatal, we should be able to create sufficient space to create a stable buccal hard tissue crest to support the soft tissues on the long term. Working with this protocol, we got now long-term clinical results, stable results with high aesthetics. But we have to prove it. So, based on the first clinical research, we studied the fate of the buccal crest by subtraction of CBCT scans at different time points. And we found that we were able, indeed, to create a bone graft in front of our implants of, on average, 2.4 millimeters, which compacted within 2 years to a dimension of 1.8 millimeter. The decrease of 0.6 millimeter is comparable with an average width of the buccal crest. We also found a gain in vertical crestal height of 1.6 millimeters. And that is the explanation why we are able, using this surgical approach, to compensate for an already existing mid-buccal recession. In this case, you can see there's a recession present, and only by performing this surgical approach, we can compensate for that recession. Nowadays, we are busy with a prospective cohort study, which is still going on, but the 1- and 3-year results are totally in confirmation with what we found in the retrospective study. We also studied the aesthetic outcome. And just by performing one flapless surgery, we are reaching very high aesthetic outcomes. The survival rate after 1 year in both studies was 100%. In our prospective study, 1/3 of the patient population showed a bone defect prior to immediate replacement. And in those cases, surprisingly, we found a slightly better pink aesthetic outcome than in the intact socket cases. We can explain that because the buccal crest will be lost within 8 weeks post-extraction, so we end up with a slightly horizontal loss. While in the buccal crest defect cases, we are able to over-contour. If we want to perform high aesthetics, then we have to create an abundant volume of soft tissue. And we want to create a stable hard tissue dimension underneath it. And at this slide you can see we prefer to place the implant behind the socket and not into the socket. And well, thanks to the design of the Noble Active implant with the sharp windings and by use of a hand driver, we are totally in control of implant positioning. Also, we found in the prospective study that in some cases, in our attempt to create a screw-retained crown, we tilted the implant with the tip towards the buccal crest. And in those cases, we found loss of the buccal crest within 1 year, probably by obstruction of the blood supply from the apical. And we ended up with buccal concavity in those cases. We're not always able to position the implant exactly as we want to. Joe, you published a nice classification, and in class 1, 2, and 3 cases, we are able to choose our position. But in very narrow ridges, we are only capable of placing the implant in one position, and that is the correct position. We are reaching very high aesthetic results in those narrow cases, but they are very susceptible for complications such as bone loss. So the next slide is showing you how to position the implants, and Tristan is taking over with his clinical cases.
Thank you. For me it changed in 2007. I was, by coincidence, introduced in the pre-launch group of Noble Active. Jose, you were there too. You were all there, I think. And then we were able, till that time, we were placing the implant in the socket. And that's what we called immediate replacement. We thought that the implant was a replacement of a root. We copied the root in titanium. And I think, as you saw on the slides of Edith, that was a wrong idea, because we block the possibility for bone ingrowth on the buccal. With Noble Active, we were more possible to place that implant really in the palatal wall. We had a small preparation, we were maximum in control of the implant, and we could even put the implant after we filled the socket with bovine bone. That implant position and what we did before, when we started with it, Edith, we get a lot of criticized, and a lot of people said, look, immediate implants, yeah, you can be successful in osseointegration, but you get mid-facial recession. And in my opinion, it was because of the position. We tried to replace a root. We even have implants which called replace. We had like Noble Perfect, like a shape of a root. That was what we are doing. And that's why I want to show you this case. This case is a guy, a Dutch guy, who is biking in Germany, get a fight with his friend. His friend punches him in the face and he gets sore teeth. After 2 days, he goes to the dentist in Germany. This dentist extracts the tooth and do two root channel treatment out of hand. We know all what happens then. You will lose your PDL. And if you lose your PDL, in fact, he has 2 implants. And if you have a close look, this is exactly what we saw from all those early cases. Placing implants, filling up the socket. Those are perfect implants, perfect shaped, placed in minimal invasive surgery after doing the treatment. The question is, can we solve this and how to solve this? And Jose, this is a real class 3. This is a real class 3. And the question is the buccal bone really important? Or we saw on Edith's data that in ridge preservation we can gain height. The question is how much? I decided to try. And there is another thing. There is nothing wrong with trying in this kind of cases. Some people say, yeah, maybe it will not work. I think the best thing if we extract is do a ridge preservation. I think we all agree. That's the best start after extraction, whatever we do. We place the implant behind. I can be wrong, but if I'm wrong, I take the implant out after 8 weeks and still I have my ridge preservation. I have nothing done wrong to that patient. But I decided here to do it. Place the implants. We can plan and look at the CBCT. You can place them in bone. You just have a 3-wall defect in front of that implant. That 3-wall defect is a wet dream of the one who wants to do an augmentation. This is perfect. Place the implants. I was more a GP at that moment. I didn't make a lot of pictures, so I just only can tell you. But what we did, place the implant, just mobilized a bit, did not flap, filled it up and make 2 temporaries. And this is the result of 10 minutes of surgery. This is only 10 minutes and 3-dimensional thinking. There is one thing we have to realize. We are going into these protocols. And these protocols means that the implant is in scalloped bone, very scalloped bone in this case. So your implant's abutment connection is deep down, it's deep subcrestal. And now it gets more difficult, because now we need a team approach with the technician. The technician has to realize that this abutment has to be pristine, biocompatible, slender, and has a good seal of the implant. That's not easy to control. That will be the biggest challenge in the future. Now we know about the implant position, but the abutment is very difficult. If we look at the research, Edith, you show we gained some height, but we gained so much height that we are mid-facial, which is the worst, 1.2 millimeter above implant level. So in the research, a lot of those abutments are really subcrestal. And that's what we really have to realize. If we want to have a stable result, this is after 9 years, and he's not the best cleaner, he's not the best lifestyle. But look, mid-facial, there's still no problem. It's still, this is 9 years after that easy surgery of a class 3 defect. The bone sets the tone. There's an interesting case. This is a girl who entered the clinic, and she has an implant of another company on the 2-1, done in a delayed case, augmentation placed. You see it's very narrow. And she has an inflammation on the 1-1.
Oh, hello.
She came in only for the 1-1. The dentist asked to do an immediate replacement.
Question.
I said, no, I want to do it, but I want to do them both. And this is interesting, but look, this is a class 1 and a class 3 next to each other. In a thin phenotype, Joe. Yep. thin phenotype, implants next to each other with an inflammation. Let's see what happened. I did just immediate protocol. I don't care about the buccal wall. I really don't care, because I have the walls around. Take the implant out, the tooth out, and do 2 implants in the protocol you just seen on the video. This is how she leaves the office. The 1-1 has more gingiva than the 2-1. But let's wait, because the bone sets the tone. We make 2 crowns, zirconia part, subgingivally. I want to have a perfect coronal seal. And this is after time, and look what happens. The 2-1, which has no bone, which is a class 3, really overtakes the 1-1 in volume. So the question is it really necessary to have a buccal wall? I don't know. I'm not sure. There are cases where it's not necessary. This is what happens also in a very fast and simple surgery. Just trust your 3-dimensional diagnosis. Coronal seal. This is where we will be talking about in the next years. We have focused on osseointegration, but we forget that the most important thing maybe is the seal of the implant from the outer world, the coronal seal. This patient, I have to redo a crown, an implant-based crown, 6 months in the mouth, but the color was not okay, and I removed this. And this is what we called coronal seal. I want to have adhesion on my implant. If it's not biocompatible, if it's not pristine, if it's not clean, we never get this. And the problem is, we all see too much the abutment that it belongs to the crown, and that's not true. The abutment, which we send to the lab, which is everybody touches, which is polished, maybe glazed, belongs to the implant, not to the crown. And that's why I'm very happy that now we are going to new systems and going to 1 abutment 1 time. Because if I can place that abutment in surgery, I can place a pristine abutment. I can get mucosal integration. I don't have to worry if I get non-original components, if the lab does it in the right way, if it's not polluted or glazed, or I can completely trust that. So I decided to try to do a case on 1 abutment 1 time. The problem is we don't have really the correct thing, so I had to try on this case on 1 abutment. We made a planning for a temp shell, made a planning for the position, look if we have enough space to the buccal, and we placed the implant in the surgery you saw, the same surgery as you saw before, placed it on 1 abutment and a temporary crown. We made a temporary crown with that temp shell, and this is how she left surgery, and on the other picture after 4 weeks. And this is the final result. And if you look at the final result, excuse for we placed this crown last Friday, so it's a bit dried out, and you can see some blood because I have to remove some cement. We have done a cemented crown because we are not able to do angulated screw channels on 1. But if you look at the gum, if you look at the control, I don't have to check my lab. 1 abutment 1 time is a very nice protocol, I think. The only problem is with the conical connection now and with the implants we have now, it is a bit bulky. So we need something different. And you have all seen what the future will bring. You have all seen what we got, something different. And that's why I am so enthusiastic about N1. Because it gives us the buccal space, Edith. We find out in implant position, because it's its shape. And it gives us the possibility of 1 abutment 1 time protocols with slender implants, with very nice materials like skin. And I think this will be really the next step, which gives us same or even better results, but especially more control about the procedure. Because I repeat, the biggest problem, in my opinion, of immediate implants is not surgery. We all know where we have to place the implants. The problem is the crown and especially the abutment. We don't have any... In fact, if you realize, it's stupid. We implant in a sterile room. We have an implant which we don't want to touch. We don't do anything with it because we are afraid that it will not osseointegrate. And then we make an impression, and the lab will make the crown and the abutment. And the abutment, everybody touches. It's on the cast, maybe it's glazed, and that we expect to mucosal integrate. It will not happen. This will be the challenge of the future. Thank you.
Thank you, thank you. So, all right, ladies and gentlemen, you hear two groups of speakers talk about the importance or not so importance of a buccal bone, all right? After you listen to this presentation, how many of you now in the audience feel that it is okay to do immediate implant placement in the aesthetic zone with compromised buccal plate? Can I see your hand? Wow, look at that. That's very interesting, all right? So maybe you convince some of the people. Now, clinically for me, when I look at my own situations, actually I found very similar type of situations. Buccal plate compromised, I can do immediate implant placement and graft. I can actually get pretty reasonably good result. But I have a question for you guys. Does the size and the shape of that buccal bone defect plays a role in your decision-making process, or it doesn't matter? Doesn't matter the size defect, whatever, as long as there's defect, you put implant in, you graft, and it's going to be okay.
Well, as long as you have a favorable bone defect, that you can have bone ingrowth from the interdental septa and from the cranial, then the bone defect at the buccal may be 12 millimeter, 13, 14 millimeter. That doesn't affect your outcome.
And what you call favorable is so as long as the implants are placed within the bony walls occlusally. Is that correct?
Yes, you have to reach... Oh, I'm sorry.
No.
You have to reach primary stability, of course.
Okay.
And you have to have the possibility of bony ingrowth from the interdental septa.
So what happens, let's say, if the adjacent teeth have periodontal problems, have interproximal bone loss, will that still be okay?
No.
Yep, go ahead.
Joe, can I say something maybe very controversial?
Everything you say is controversial, so it's okay.
We have to consider if we have a tooth with a very thin buccal plate and thin phenotype, if it's not better to remove the plate, because then we can internally overcompensate with the augmentation. And we have more bone substitute than we have with the plate. And we know the plate will resorb. So we already tried some. I'm not going to say that you have to do this, but it's something I consider. If we are all agreed that it's not necessary and disappear, maybe it's better to take it away and overcompensate.
Okay, now that's a very controversial thinking process here. But if you guys think about it, all right, what everybody's showing is this: when you guys do when you guys are doing the grafting in an intact socket after immediate implant placement, inevitably from the CBCT scan, the buccal bone to a certain degree probably resorbed. Therefore, you can notice there's a little tiny collapse. Under such circumstances, that's why it promotes you say that maybe you should remove the buccal bone and just overgraft it.
Yep.
Now, would you consider about grafting outside the buccal plate? What do you guys think? You know, not just grafting inside, but grafting outside to compensate for that inherent degree of collapse of the disappearance of the buccal plate. What do you think, Gabor?
I personally do not feel comfortable doing that, because I think just raising the flap is might be a wound too much. But I know that's also controversial. Many people do that. I graft significantly less than most of the people I know. And if I graft inside. Okay, the panel, quick question. Just raise your hand. How many of you feel that it is better not to raise the flap? Better not to raise the flap. Okay, so now we have a situation, no buccal bone, all right? And no buccal bone because of infections and things like that, all right, infections. Without raising the flap, how can you really delineate exactly the shape of the defect? How can you truly clean out
the granulation tissue, because sometimes granulation tissue is not just isolated in the socket. It can be already connected to the periosteum, right? So how can you assure that? And on top of that, grafting, won't it be easier if you raise the flap and you can really do a nice clean GBR with the barrier rather than just shoving something in there and hopefully it will stay? Where do you stand, Jose?
Well, definitely in those cases, if there is a big apical infection or bigger apical infection, I would open a flap and I would graft as needed and come back to that defect at a later time. If it is a minor defect that you have a little fenestration, maybe I might even raise a more apical flap just to clean that defect and graft there and maybe then place the immediate implant.
But do you feel the same way, Tristan and Edith?
Totally agree. Flapless doesn't mean that it's flapless for me is that open the papillas and the buccal part. But if you go more apical, no problem.
Okay, so the audience, you got to remember, flapless is not like for every single situation. No. Sometimes you either raise the flap now or you may need to raise the flap later, which is something not good. One question for you, Oscar. Talk about grafting outside to overcompensate. I know where Gabor stands. Where do you stand on that? I mean, how do you feel?
Overcompensating outside of the envelope of the bone, at least we should think that maybe it's not that predictable. We can try. We can do it. But for sure, in that type of situation, either you have no buccal plate at all, or you have to open a flap. There is no thing in the middle. So I would say that maybe it's not that predictable, but sometimes we try to overcompensate. Otherwise, we will compensate that with soft tissue graft after all. That's what we're doing many times now.
So what you suggest is when you do immediate tooth replacement, you will maybe do a little tunneling pouch and then do a CTG.
That's exactly what I normally do.
Okay. All right. Very good.